Okay, so thanks for coming today to the AIHI seminar on toward healthcare improvement. I'm Professor Henry Cutler. I'm the director of the Centre for the Health Economy at Macquarie University, but also one of 4 research centres within the Australian Institute of Health Innovation. I want to start off with acknowledging the traditional custodians of the land on which we meet, the Wadamallagal clan of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since time immemorial. We pay our respects to elders past and present. Okay, so we have a very exciting seminar today, and I also want to extend a warm welcome to Professor Trish Greenhalgh of the University of Oxford, who is leaving tomorrow, I believe. So tonight, wow. So we're very privileged to have you here, considering that you're off on the plane. But our seminar today will run through a series of presentations. So we have Dr. Annie Lau, who will talk about consumer informatics, Reema Harrison, who will talk about improving care for people from culturally and linguistically diverse backgrounds, Robyn Clay-Williams, who will talk about improving access to emergency departments for priority populations, myself, who I'll talk about mental health care funding and the consultation process we're currently going through. And then we'll finish it off with Trish on patient safety in remote primary care encounters. Just to give you a brief introduction of Professor Trish Greenhalgh, she's a general practitioner and professor of primary care health sciences at the University of Oxford. She leads a program of work at the interface between social sciences and medicine, focusing on complementary roles of scientific evidence and narrative in the clinical consultation, the organisation and delivery of care, and the challenges in meeting the needs of disadvantaged and underserved groups. Professor Greenhalgh is the author of over 400 peer-reviewed publications and 16 textbooks. She has an OBE for services to medicine in 2001, a fellow of the UK Academy of Medical Sciences in 2014, and was elected International Fellow of the US Academy of Medicine in 2021. So we are very pleased to have Trish with us today. But without further ado, I will hand it over to Dr. Annie Lau, who'll talk about consumer informatics. Each presentation will be of 8 minutes, and Chrissy will enforce that rule. But Trish, given that she is a guest, she will have an extended 30 minutes. Please, if we can hold our questions to the end, because we have a 20-minute discussion where we can bring it all together. Great. So thanks, Annie.
Very much, Henry. So lovely to be here. I actually haven't timed my talk, so for those who don't know me, I'm Annie Lau from the Centre for Health Informatics, and I look after the Consumer Informatics stream there, which is anything to do with digital health for patients and consumers. Today, I'm going to outline for you 2 projects we have in the team, and I chose these 2 projects because I think they are a bit aligned with what Trish is interested in, but we are taking them from a very different angle. So the first one is called Patient Work at Home, which is basically we give people body cameras, which are like, the cameras that police use. You wear them around your neck, and then you automatically films what is it that they're doing out around them. And we give body cameras to people to capture the types of health work they do at home. And the second one is looking at the appropriateness of GP visits for teleconsultation. So let's start with patient work first. So we started this project as sort of a rebellious response to the rise of AI, wearable devices, and smart home technologies. Because like many of my colleagues were actually using these technologies as a solution to address healthcare needs. But we all know that there's actually a very high abandonment rate of these types of technologies. So rather than using these technologies as a means to a solution, I was actually using these technologies as a means to really understand the experts, how these experts actually go around at home looking after their health. And so for this study, we focus on people with multiple chronic conditions where they've actually managed to keep their diabetes well controlled. So these participants have an average age of 72, and they've been diagnosed with diabetes for an average length of around 19 years. And so this data collection took over 3 days, where we visited participants in their homes and we conducted an interview, asking them like how they actually look after themselves, and asked them to show us where you keep your medications, where you actually, how you keep track of your medical appointments, how you process your medications, etc. Then we gave them the body camera to teach them how to use it, and leave them for a day to use the body camera as they wish. And along with that body camera, we also asked them to fill in a paper diary to note down the time that they use on different types of activities during the day. Then on day 3, we went back to visit them at home, download the video footage from the body cameras, ask the participants to delete anything they don't want others to see, because we really respect their privacy. And then we sat through with them, asked them to go through those photos with us to show them what is it that they do during the day. As far as we know, I believe we are the first group that actually uses a body camera to capture the routines of people with type 2 diabetes and other chronic conditions. We've collected over 400 hours of body camera data, and we developed a deep learning model to actually classify this video footage into 12 classes of daily activities. So we saw a lot of watching TV and food preparation, exercising, driving, using electronic devices. And we're still analyzing the data as we speak, but we've got some early results where, okay, here you go. So where patient work amongst our participants changes over time in 4 different types of trajectories. And during COVID, we followed up with our participants with a telephone interview to see how they're coping. And like most of us, many of them have developed both positive and negative self-care behaviors. And in order to bypass those very strict social distancing restrictions during the pandemic, many of them have had to develop workarounds and in order to cope during that time. And workarounds are not necessarily bad. They were actually essential for them to get on with their lives. And as you can see with this really rich data set that we've got, Nida, who is one of our PhD candidates, is actually going through this data set to actually try to assess what are the safety risks in the homes of older people. And because we've got this camera footage of their homes. And from that, we're going to draw on implications on what are the remote monitoring and smart home technologies we could actually introduce that hopefully would reduce the high rate of abandonment. So that was the first project. Now we move on to the second project. As many of us know, teleconsultation is now a permanent feature in Australia primary care, but a lot of it is actually conducted over the telephone, almost 90% or more. So but there's not a lot of guidance on when it's actually appropriate to use teleconsultation. Yeah. So we are actually asking a very simple question. With a lot of the, say, GP visits we see during in-person, how much of that GP consultation can actually be conducted using telephone or video? So things like measuring blood pressure, can we do that over telephone or video? Listening to your chest, can we do that over telephone and video? So this is the question we're trying to ask. So I was very fortunate when I was in the UK a few years ago, I met Professor Fiona Stevenson from UCL, who has kindly shared with me a database of more than 200 videos of in-person GP consultations. And we developed a hybrid manual and computational models that extract the types of tasks and GP and patient interactions from these videos. Tasks such as measuring blood pressure, ordering medications, ordering blood tests, etc. And then together with GPs, we developed this matrix, a very simple matrix that go through each task and give a mark out of 10 to see whether this task can actually be conducted over telephone or video. And we applied this method onto the video recordings, focusing first on chronic conditions, because chronic conditions was the condition that the RACGP has suggested that it is appropriate for teleconsultation. We found that it is quite appropriate for teleconsultation, scoring a 7 out of 10, because tasks such as like medication prescription, blood pressure monitoring, etc., they can be conducted over the video, over telephone or the video. And but if we delve into the types of chronic conditions, some chronic conditions are easier to conduct over teleconsultation compared to others, such as like diabetes and CVD, where there's a lot of discussion over lifestyle, a lot of ordering blood tests, etc. So these are more appropriate. But then say chronic conditions, respiratory ones like asthma, where there's a lot of listening to the chest, looking at your ear, nose, and throat. So they may not be so appropriate for teleconsultation. And we're also looking at other conditions and cohorts as well, such as musculoskeletal, mental health, children, and older adults. So I know I've gone through this very quickly, so please feel free to come up to me if you want to know more details. I'm here the whole morning. And I really want to take the opportunity to thank Karen and past members of the team for their amazing contribution, because without them, these bodies of work wouldn't be possible. Thank you.
Now we have Associate Professor Reema Harrison on improving care for people from culturally and linguistically diverse backgrounds. And I'll apologise, Annie, because I didn't read your bio out, but I will read Reema's out. Don't hold up. Don't. It's not a personal thing. That's my problem. Reema leads the Healthcare Engagement and Workplace Behaviour Research stream in the Centre for Health Systems and Safety Research, and is a Cancer Institute New South Wales Career Development Fellow. Her program of research investigates how increasing stakeholder engagement can contribute to improved healthcare quality experiences and outcomes. So thank you, Reema.
And so I'm going to talk a bit today just about one particular project, but it's part of a wider program of work in which we're looking to improve care for people from different cultural and linguistic backgrounds through consumer engagement. So I'm hoping that, given that discussions at the end, the 8 minutes will be well used over these 3 sections. So the project I'm going to talk about is familiar to some people here, but this is a project that's been running over the last 4 years. It's funded by a couple of different sources, and it contains a wide range of studies. And so just to give you a background, everything I'm going to talk about is embedded within this, but this is the entirety of it, and I'm happy to answer and talk about things broader to the content here. So the backdrop to this work is really a understanding from a range of work that we were doing around safety outcomes that people from different cultural and linguistic backgrounds, firstly, are described really poorly in the healthcare system, but secondly, through a literature review of work led by Ash, sitting there for his PhD research, identified that consistently, despite the variation in the ways that we identify this population, people are exposed to safety events in their healthcare, perhaps more often when they're from a different cultural or linguistic background from the country in which they're accessing healthcare. Particularly, we identified that areas where we know there are quite common areas of safety events like medication safety and healthcare-associated infections, they occur more commonly in the case of people who are often from a different cultural background, particularly when there's another language involved. And so, for example, we were finding things like up to 30 and more errors in interpreter communications around healthcare, underpinning a whole range of medication and medicine-related problems in particular. We also identified from some qualitative work that surrounded this project beyond this review that there was a general sense of feeling unsafe within the healthcare system. So the qualitative work was conducted with people who'd accessed lots of different kinds of healthcare in lots of different places, and that sentiment really carries through. For us, of interest really was the absence of evidence in cancer services and very limited evidence within the Australian context, which, given the different ways in which the population are identified in different countries, was quite important for us to understand what's going on in the Australian healthcare system, where the term CALD is used, and we think about it in that way. So we embarked on a piece of work which was doing a medical record review, looking at records across 4 different cancer services across New South Wales and Victoria. And again, as Ash will attest to, although we only have 600 records, it actually took a huge amount of time, and it was a huge piece of work. And so, you know, for the whole period of Ash's PhD, he was actually working on identifying the cohort and extracting data, and with the support of a range of other clinicians and staff within the project. And so from that record review, from 628 records, we identified that there were patient safety events for 1 in 3 of the people who we had identified a record for. And so although we didn't extract this for a general population, that is a higher rate than we would have expected. We were looking at, you know, something around the 10 or 20% mark, given the wider literature about the range of patient safety events that you would normally identify. We also identified that in the records where there was more than one safety event, having a language other than English was a key feature of those patients, but also having interpreter not required as documented in their medical record. And so there was something about the potential use of interpreters and recognition of when an interpreter might be appropriate that we thought would be worth exploring a little bit more. So in the background to the literature review and to the qualitative work behind the Can Engage project, we identified a range of factors that I think would be unsurprising, but are worth kind of identifying here, in that they contribute to the inequities that we've identified in healthcare quality and outcomes, and that there's perhaps too much of a focus only on language proficiency when there are a number of other factors at play. And so we know that people's reasons for migrations and their cultural beliefs, social inclusion, and their overall engagement at every level of the healthcare system, you know, really from kind of the system level through to the individual level, was an important factor in terms of the outcomes that were being experienced. And that's why we took more of a central focus on engagement when we started to think about possible solutions through the course of the work. So we started, Bronwyn Newman, who's a research fellow on the project, led us a review of existing patient engagement interventions that were specifically in kind of direct care. So, you know, those clinical encounters predominantly. We were trying to look at whether there was anything that might have been used or that could be useful for people from different cultural and linguistic backgrounds specifically. I think to our surprise, we identified quite a number of different strategies, but no evidence of their development with or for people from different cultural backgrounds, or even a subset analysis or demographic data that could give you a sense of whether these interventions were potentially going to be appropriate or work similarly for people from different cultural or linguistic backgrounds. And so that was a really important basis for some of the work that we then progressed. So we took these tools, so identified, you know, things that you are very probably familiar with, which are, you know, procedures and workflows that try to include patient engagement, digital tools to try to improve communication, and then also strategies that occur at the bedside. And we took those broad types of engagement interventions, and we took them to some workshops across Australia with predominantly these were leaders of consumer organisations, whether that be in cancer or be in various different areas where there is an interest in cultural diversity. So there might be particular cultural groups or people who have a broader interest. And from those workshops, we were led by Catherine Joseph, who's a research fellow down in Victoria. We identified that there's certainly potential for adaptation in the ways that we often think about, you know, using visuals, using culturally appropriate content, and thinking about framing the messages within these interventions to be more inclusive of families, for example, or other decision makers who might be important. We also identified that there are some more substantial challenges in terms of trying to think about just making adaptations to interventions that are already out there. So certainly the concept of patient safety, you know, for people, particularly humanitarian migrants, people who've come from different healthcare systems, can be quite at odds with patient safety and the understanding of that from some of these interventions and the way they're framed. Also preferences and thoughts around engagement, how people would like to be engaged in their healthcare, who should lead that engagement and how that should occur. They'd be quite different. And so we took that with us into the latter stage of the project. And so really the final parts of the project were co-designing solutions, and that's been going on over the last 18 months or so in New South Wales and Victoria. We've done 3 co-design processes kind of from start to finish, and several workshops and meetings and discussions that have gone in each one of those. So each one's quite an extensive process. And through those processes, we've developed different things in different places, depending on the site. So we've developed things like a translated medication communications tool that's shown up there. That's in Russian and in Mandarin. We've also developed some service navigation tools for in-services. And more recently in Victoria, a patient-held tool that's about improving continuity of care between the primary and specialist system. We've also engaged heavily in thinking about co-design and how we do that when we're working with a really diverse group of people. There's lots of information out there about how to do co-design, but certainly some major gaps around how to do this with this population. And so that's been a major aspect of the work. And that's all for now.
Thank you very much, Reema. We now have Associate Professor Robyn Clay-Williams. The topic is improving access to emergency departments for priority populations. Robyn leads the Human Factors and Resilience in Healthcare Research in the Centre for Healthcare Resilience and Implementation Science. The program bridges the gap between theory and practice by developing products and processes that are usable and ready for implementation. Thank you.
Great. Thank you, Henry. Okay, so I want to talk to you today about one of the projects that we're doing in our program. So I lead a program at CHRIS, the Centre for Healthcare Resilience and Implementation Science in Human Factors and Resilience. And the one I want to talk to you about today is the work that we're doing in hospital emergency departments to try and improve care for some of the more vulnerable patient cohorts that we see in emergency departments. So we started this project by Lil Austin led a systematic review looking at what interventions have we done in emergency departments internationally so far, because we're not seeing any change. Emergency departments, if anything, the performance and the ability to treat patients has actually got worse over time rather than better. So before we started, we thought we'd have a look and see. And you can see here that there's many interventions that have been tried in emergency departments. We've categorized them into practices and processes or in terms of team composition. But one thing that we've found is that there's very few interventions that look at the emergency department as a system. They're often piecemeal interventions. And when you find a system that's got a closed system in terms of resources, where resources are constrained, if you get these individual interventions, they suck the resources from the other areas. So, you know, you wonder why they don't work. Well, that particular one might work, but then, you know, the other parts of the system degrade. And they also don't necessarily look at how the new intervention might interact with other interventions already in place, and you often get duplication and redundancy and so on. So our project is looking at developing and validating evidence-based and scalable clinical models of care that improve acute care and reduce the pressure on Australian EDs. And in short, we're calling this MyED. It's a bit less of a mouthful. And this is the team up there on the top left. So we've got 3 aims in the project, and we're about 12 months in, just over 12 months in at the moment of a 5-year project. So the first part's to have a look at what are the needs and preferences for the delivery of acute care in Western Sydney, which is the area that we're working in, which is a low socioeconomic area of Sydney. And we're looking at the needs and preferences of our 5 priority consumer cohorts, and I'll tell you about who they are in a moment. And also the needs and preferences of the ED clinicians who treat them. So once we've elicited those needs and preferences, and we're quite a long way through that now, we then go into the second phase, which is co-designing, developing and implementing interventions with those groups. So we'll be running co-design workshops with both clinicians and consumers in the various groups to develop these new or modified models of care. And then once we've got the models of care, they're going to go through a business case, which Henry Cutler's group is going to be doing for us. And those that that do well from the business case, we're going to implement and scale across Sydney and then across New South Wales. And there's the protocol for the first part of our design, if anyone's interested. So the 5 groups, the 5 cohorts that we're looking at, and I should say to start with, this is an artificial division of people. There's a lot of overlap between these cohorts. So we're looking at older adults, so they're people aged over 65, but really the sort of the group that we're looking at are really those older adults who have a lot of comorbidities. Maybe they come from an aged care facility, or they may live in the home but with an aged care package. So we're looking at those older adults who have probably greater health needs than the average. We're looking at people with a disability or adults with a disability, adults who present with a mental health condition, Aboriginal and Torres Strait Islander peoples, and the area that we're looking at has the largest metropolitan concentration of Indigenous people in Sydney. And we're looking at people from culture and linguistically diverse backgrounds, and Reema's already given you some information on what we mean by that. So the tool that we use, so before we started talking to people about what their needs and preferences were, we've developed a model of the emergency department that is going to help us implement our changes and to understand what those changes mean for other things already happening in the ED. So the development of this work was led by Lil Austin. And it's a cognitive work analysis. So this is a human factors tool, and it allows us to model systems and to understand the interaction between different components of that system. So it consists of 5 phases. So there's a work domain analysis, which tells you all about why the system exists and allows you to model the system and the constraints within that system without the people in it. So you're just talking about the system without the people. The control task analysis talks about where and what activities are performed, which is quite critical in an emergency department because often there's multiple demands on particular areas or parts of the emergency department, whereas some other areas go unused. The strategies analysis looks at how activities are performed and allows us to look at, are there more optimal ways to perform activities? The social, organisational and corporational analysis looks at who can perform them. And at the moment, we find that some clinicians within the emergency department, whether they're senior nurses or some of the doctors, are very heavily loaded in what tasks they need to perform. And there's possibility for some of those tasks to be distributed. And then the worker competencies analysis is then the level of cognition required to do those particular tasks. So what can this WDA model tell us? It can tell us what purposes or measures are in conflict. So I've got a little diagram now. I don't know if you can see it, but they're the 5 phases of the emergency department. It talks about the functional purpose, which for the emergency department, it's to get people into and out of the hospital, but it's also to provide safe and timely care. And one of the issues, if you think about safe and timely care, is they are completely in opposition to each other. If you want to provide safe care, it's going to take time. So we already know that, from the models, that the functional purpose is already in conflict. And then as we go further down, we can have a look at the values and priorities, which are all those things we use to measure whether we're meeting our functional purpose. So in EDs, unfortunately, a lot of the KPIs are to do with time and very little to do with the safe care. So lots of things about getting people through in 4 hours and, and so on and so forth. And then further down, we have a look at the purpose-related functions, so the things that the people actually do within the emergency department to achieve those aims. And then as we go through, right at the bottom of the model, all the different things that you have in the emergency department, whether it's an ECG machine or the beds or the computers or IT equipment and so on and so forth. So when we put a model of care through this particular work domain analysis, we can see immediately what effect that's going to have on the rest of the emergency department. We can see whether measures or purposes are in conflict. We can see what the effect of our new intervention will be on other ED work. And we can see whether we need new or increased resources in order to implement that straight away. So it can tell us, for example, whether we need more staff, how best to allocate that staff to tasks, and how to optimize tasks. So that's just a very, very brief. So far, just to give you an overview of what we've done so far, is we've completed the analysis of observations in the ED. We've completed the analysis of the clinician interviews, and the analysis of some of the patient interviews with the older people and also with the culturally and linguistically diverse groups. And we're about to next year go on towards the co-design process.
Thank you very much, Robyn. Now it's me. And I won't go through my bio because I've already done that. But so I'm going to talk about today a project that we started about 1.5 years ago. It's being funded by the National Mental Health Commission grant. It's on how to embed greater value into mental health care funding and investment. And the premise of this research is really to start from a position whereby the Productivity Commission finished in 2020 when it released its landmark inquiry into mental health care. Within that inquiry, it noted several deficiencies within the mental health care system, including roles and responsibilities for mental health care delivery and evaluation were unclear. Mental health care data was underutilised, and fit for purpose data was not collected. There was little measuring and monitoring of health outcomes and little accountability for mental health outcomes. And programs are not being measured for their cost effectiveness, nor was there little translation of research into practice. Since then, there has been some movement within the mental health care system, but the Productivity Commission stopped short of significant funding and investment reform. Instead, they made some recommendations around tinkering with funding and investment, but they explicitly said that mental health care funding should not be allocated based on outcomes. And their primary reason was because they also suggested that outcomes weren't measured well within mental health care, and therefore it would be too long a bow to draw to start moving towards that type of environment. We've picked up on that and we've said, okay, well, we believe that mental health care funding and investment should be a long-term proposition, and it should move towards outcomes in the long term, but there is obviously a road that we need to travel down in terms of collecting additional data, improving information technology infrastructure, and providing support to providers. But our research question for this particular grant was, how can more value be embedded into mental health care funding and investment? The research fits within a number of policy directions or trends. The National Mental Health and Suicide Prevention Agreement were bilateral agreements between the federal and state and territory governments in 2022 that outlined some reform process, but it didn't really go too far. It was more pragmatic. And in particular, it didn't really touch on funding and investment at all. It did talk about local commissioning of services, but it didn't talk about rearranging how funding was allocated to mental health care providers. The MBS Review Task Force and Strengthening Medicare Task Force, they're two, again, landmark studies that have come out in the last few years. And both from a primary care perspective have recommended that the medical benefits schedule be complemented with alternative funding models to improve health outcomes. And that was really because there is a recognition within Australia that integrated care is not being delivered well, particularly the integration between primary care and other healthcare services. And they see the Medicare benefit schedule, which is obviously a fee-for-service funding model, as being one barrier to delivering integrated care, particularly given that the MBS is paid for by the federal government, while inpatient hospital services and some community care is paid by the state government. There's obviously some silo of funding and therefore introduces perverse incentives. The National Health Reform Agreement was also an agreement made between the state and territory governments and the federal government, but mostly related to public hospital funding. They have 6 dimensions of reform, and 2 of those directly relate to paying for values and outcomes. So this paying for value and outcomes, which is the first one, is effectively, it has been on the agenda for quite some time, but there hasn't really been any movement. It's still on the agenda. The second part is the Nationally Cohesive Health Technology Assessment Framework, which is really around how state and territory governments become cohesive and use a a similar approach to assessing large investments into public hospitals. So, for example, investment in new surgical technology. And then the Independent Health and Aged Care Pricing Authority has been doing a lot of work in mental health care classifications, and it's also embedding activity-based funding into mental health care. But it also has an agenda to explore other areas of care that that may suit value-based funding. So our methodology was to establish an advisory group, which we did. It was an external advisory group. It has a number of individuals, both representing government, non-government, and also academic. We undertook a rapid literature review on funding and investment, and we wrote a consultation paper that was released in August. That's been on our website and distributed to thousands of people, actually, and it outlines mostly two components. One is a structure for embedding greater value into mental health care funding, and there we propose that an independent value-based payment authority be developed at the federal level that is responsible for developing value-based payment models, not only for mental health care, but also for other types of care delivered within the healthcare system and services that are delivered outside the healthcare system that potentially impact outcomes. And the idea is really to bundle some of those payments together to facilitate the integration of care across different service types: physical health, mental health, and other services, for example, justice, education, and housing. We're currently finalising a consultation phase, so we have nearly interviewed all state and territory government departments, Department of Health, but also mental health care commissions. We are also undertaking a number of workshops, so we've held 2 workshops so far. That has around about 35 people each, and we've got one more which is specifically focused on consumers that will be held at the start of November. We are undertaking a thematic analysis of interviews and a schema analysis of workshops, and that's being primarily led by Professor Frances Rapport, who has been, an absolute goldmine in terms of undertaking qualitative analysis, considering this is an area or methodology that economists don't typically use. And we're looking to write a final report by January, but also release a number of papers, one on funding, the other on investment, and hold a one-day workshop / seminar. Just to give you a quick overview of some thematic themes that are coming out from our analysis. Throughout, this is a thematic analysis of the interviews that we've been undertaking, and there has been obviously focus on patients, workforce. Individuals want a funding model that is practical and equitable, and there's been some conversations around whether it would fit within existing funding models, how it would bridge system and service fragmentation, but also people are saying there needs to be some evidence around that, and that may be somewhat difficult considering this is a new funding model that would be introduced into the healthcare system, but there are some precedents elsewhere. Other themes are governance, particularly how a funding model and investment would be governed across the system, particularly the split between state and territories, PHNs, LHNs, and federal government, but also across providers. And then also there was a theme of resistance within our evaluations as well, not really knowing where to start, focusing on past failures that have occurred through pilot programs of value-based payment models. So to wrap this up, there has been some tension between stakeholders on funding that needs to be addressed in any model. The government has really focused on the intervention process. Providers are focused on risk, particularly financial risk, and consumers have really focused on outcomes. There's been a lot of discussion around what is an appropriate outcome to measure within mental health care, considering there is such heterogeneity. We still need to complete several tasks, the consultation process, the 2 papers that I've mentioned on funding and investment. We are organising a seminar, and we'll be distributing those papers to government agencies and departments with subsequent meetings once they have been published. So that's me. I also wanted to acknowledge my other authors, which Alicia Norman, Dr. Anam Belgrami, Associate Professor Jonas Fukin, I've mentioned Professor Francis Rapport, and Mona Agti. So thank you. Okay, now over to our headline act. Professor Trish Greenhalgh.
Thank you for inviting me. I'm actually technically a visiting professor here. And people said to me, where are you going today? I'm going to Macquarie University. Why are you going there? Well, because I'm a visiting professor there, but I've never actually visited Macquarie. So that's kind of why I'm here. I haven't got very fancy slides. So forgive me for that. This is like made on the plain slides, but I'm so excited about this project. And I could spend the whole time acknowledging loads and loads of people on my team. I particularly want to acknowledge Rebecca Payne, who is a GP, and she has worked for the Care Quality Commission, and she's done a lot of work around patient safety in the UK. And more recently, she's put a toe in the water of the academic pond, and she's just starting to prepare a PhD proposal with me. But she really knows so much about safety from a kind of from a kind of governance perspective and from a frontline GP perspective. So Rebecca was part of the team, and I want to get the right distance from this, because if I get too close to it, it blows everyone out, doesn't it? Okay, I'll tell you about the remote by default study. There was remote by default 1, which was someone described 2020 as the spaghetti on the wall approach to research, like, oh my goodness, there's COVID, let's chuck the spaghetti on the wall and see what sticks type thing. And the remote by default 1 was in that basket. It was very rapid research on, oh my goodness, care has gone remote. Let's just take a look at what's going on. And we put out a lot of papers there. And they were rapidly put together and rapidly published and very widely downloaded and used. But looking back, I think, God, if we'd had time to do that work properly, etc. Okay, remote by default 2 was the bit where we slightly recovered from that really big Russian pandemic. And we said, well, there's a lot of care that is still remote and digital. So it was introduced in the pandemic, and it's sort of still happening. And should we still be doing all these telephone consultations? Should we still be having remote triage? All that kind of thing. Let's breathe and let's take a look. So the design of Remote by Default 2 was that we took 12 GP practices across the whole of the UK, from the north of Scotland to remote rural Wales, where the staff and the patients speak Welsh, to inner London, to kind of middle England. And we sampled those GP practices. Actually, there were about 6 of them that we were already working with. And then we said, well, how can we make the sample more diverse in relation to population served, geography, cities versus, remote areas, all that kind of thing, but also digital maturity. And we developed a very simple 5-point scale of digital maturity, from not even the telephone works to not only are they being really strategic and really slick with their own digital stuff, but they're also helping other practices. So that was the other end. So on that 5-point scale, we had the full stretch, and we've been following them for 2 years. Each practice has a researcher in residence. So one of my postdocs gets to know that practice really well, makes friends with the receptionists and the managers and the nurses and the doctors, and visits from time to time, talks to patients, all that kind of thing. And so we've been following them in relation to a number of things. And the one kind of strand I want to talk to you today about is safety. Now, it became apparent quite early in RBD2, as we call it, that everyone was sort of mentioning safety, but we never identified any safety incidents. I thought, oh, that's interesting. And Rebecca said, well, you should come along to those national meetings that I go to, because they always talk about safety incidents. Because guess what? You know, when something really bad goes wrong, a baby dies or something like that, someone gets sued, then you get the safety incidents. But if you're in a nice GP practice in the middle of nowhere, when most people aren't particularly ill, you don't really pick up major safety incidents. It's a bit different from the cancer example that we've just had. You know, I'm a cancer survivor. It is scary. I've been in there with neutropenic sepsis. It's high risk. General practice is a bit different. You know, can I check my blood pressure and can I have my medication? It's not such high risk. Okay, look, I'm a bit embarrassed to present this to you guys because you're the top safety people, I think, in the world. You've got safety 1 and safety 2, but just in case there's someone here who doesn't know this, and I know you all do really, the safety 1 approach is that you analyze safety incidents. Something terrible happens and you go through one of these forms and you say, well, hang on a minute, why did that happen? Upstream, why did that happen, et cetera, et cetera. But the safety 2 analysis is, why don't things go wrong more often? What are people doing in relation to articulations and workarounds and all the stuff that we don't normally capture that make healthcare organizations safer than they would otherwise be? And Rebecca, who'd been involved in these national level safety 1 analyses, was really fascinated by what we were doing effectively with RBD2. We were doing a safety 2 analysis. We were saying, why isn't there? Why aren't there? Why don't things go wrong more often? So we decided to do both. We decided to combine safety 1 and safety 2. We managed to get hold of 95 actual incidents of dreadful things that had gone wrong in relation to remote care. So this isn't safety incidents in general, it's safety incidents in relation to mostly telephone consultations. And where do we get those from and how do we get ethics? That would take a long time to tell you, but basically NHS England, sort of national body, gets complaints. NHS resolution is a part of the NHS that pays up when something bad goes wrong. And NHS resolution tries to kind of sort stuff out, but if not, they pay up and they have a database. And we actually managed to get Rebecca seconded to NHS resolution. And I have to just tell you something about the ethics before I show you some of the data. I have never seen the cases, the actual cases that came through NHS resolution, because they're real cases and, you know, someone died, someone's loved one died. So what Rebecca did while she was seconded was she systematically fictionalized those cases. So Rebecca used a technique to systematically fictionalize and then brought the data out of NHS resolution and into the university. So the information governance was a big headache for us. So now what I'm going to do, I'm not going to attempt to give you every aspect of this, but I'm going to actually give you some real safety incidents linked to mostly telephone consultations. And as I say, these are fictionalized. I think I'm just going to let you read them, actually. So what we had, the way we produced these, you can see they're not all that detailed. They're not full-on root cause analyses. They're stories, tragic stories. And Rebecca worked with another academic GP called Aileen Clark to do a thematic analysis and then to pull together these little paragraphs. And we had 95 of those. They're a little bit more detailed than that, actually, but you can see the kind of things that were coming up. And those of you who are from a health systems perspective, from a human factors perspective, from an equality and diversity perspective, you'll start to kind of abstract from this, no doubt. And I'll give you our own summary at the end. Here's 3 more. That's all you get, but you're only getting 6. Tell me when you've read them. Yeah, okay. So those are examples. Now, before I go on, I want to emphasize how rare these were. And one of the problems with looking at those and thinking, right, we've got to put something in place to fix it, is they almost never happen. We looked really, really hard, and it took a data set collected nationally over 3 years to get 95 of those. And that is not to detract from the fact that someone's lost their loved one and, you know, all that kind of thing. But we have to take account of the fact that they mostly do not happen. But we do need to learn from them. And this is my 1-slide summary of the themes that were coming up. And I don't think there are any surprises there, really. I suppose one of the things that I want to emphasize is, look, if you're doing anything on the telephone, the only channel you've got is talking and listening. It's so crucial. The building of rapport, the gathering of information, and assessing someone clinically over the telephone. All you've got is questions and answers. And in this very rare data set, that was inadequate in many, many cases. I should say that many, in fact, most of these safety incidents were characterized by more than one, many of those top bullets. And then, of course, you get the things in the bottom left, misdiagnoses, underestimate. I'm not going to read them out, but that combo ends up leading to deaths or serious harms. And then this list over here, which I think your 5 key categories, it's very similar, actually. People with multimorbidity, cardiac emergencies, abdominal emergencies, abdominal pain. I really don't like the sound of abdominal pain. When I've been looking at those, there was a lot of abdominal pain. Vague or generalized symptoms. Safeguarding issues. Interestingly, we didn't see many safeguarding issues. And I think the reason is that when the person dies as a result of a safeguarding problem, it doesn't go to the national organizations that we were getting our data from. It goes somewhere else. And so I think we've under-sampled safeguarding problems, but we still found some. Failure to respond to previous treatment. We've got another Rebecca Rosen and I wrote a paper recently. I think it didn't end up being called 3 strikes, you're in, but that was basically what we were saying. If you've had 2 phone calls and that you're still bothered, you've got to come in. Okay. So what did we find in our analysis of safety culture? So this, I think, was an interesting method because we had the researchers in residence already very familiar with one practice each. Some researchers in residence were working across 2 practices. But what it meant was that Rebecca Payne, who'd done the safety 1 analysis, could then go to the researchers in residence and say, what have you got on safety? these are the kind of things that have come up. So this set of themes, she then had a meeting with the researchers in residence and say, right, what have you got? And of course, we did search our NVivo database for words like safe, but what we really did was we informally tapped the brains of people who were familiar with the practices. And we also had sort of workshops and things like that. So what did we find? Okay. And again, I'm going to give you, I think I've just got 4 examples because they're slightly longer. I'm going to get you to read those. So the first one is an interview with a GP who's discussing how he flipped a phone call into a video. And they didn't use video much. I think it's the same in Australia. It sounds like a great idea, but it's usually just too much of a headache. But we've got in UK quite a really, really good technology called AccuRx, where you can actually, you're talking on the phone and then you can flip it over within the same contact and turn it into a video. And this is an example where the GP just plays a hunch, basically. And let you read the next one. I think in this second one, you can see how very complex the decision-making is and the extent to which one should be erring on the side of caution. And how in this practice, there is a means by which they can reflect collectively on what's going on. And then the receptionists get the message back saying, no, you're absolutely right. If you're in doubt, put it on the urgent list, and then we, the GPs, will make the decision as to whether that's urgent or not. And we talk about this quite a lot in the paper, because I think it reveals a bit of resilience in that organisation. This next one is quite an interesting. I bet the health economists among you are going to be interested in that one. So this is I think it's diabetes. Anyway, whatever it is, some of the older people are not engaging with the telephone assessment for their long-term conditions. And so this nurse just kind of pops up on their doorstep from time to time with all the blood bottles and everything, saying, can I just pop in? You can only really do that when you've got a long-term therapeutic relationship. But you can see what I would call the relationship-based care there. She's just not prepared to say, well, if they're not interested, she actually shows up. But that's pretty costly if that's the way she's doing it. And then the last one here, it's an abdominal pain. It gets the kind of my spidey sense, as Rebecca calls it, that really this abdominal pain would normally have been brought in because it'd been going on for a while and all the rest of it. But actually, the doctor's saying, maybe we can leave it because we're too busy. And so the receptionist gets asked to phone the patient and say, are you okay to wait till tomorrow? So there's lots and lots of subjective judgments going on there. General practice is what we call the risk sink of the health service. We absorb a lot of risk. And so where is the risk distributed in that case? Who's taking on that risk? And the negotiation, the conveying to the patient, look, if you really, really need to be seen today, we'll squeeze you in, but could you wait until tomorrow, without putting too much pressure on the patient? So here's a summary of what I think we found from our ethnography. The first thing is that general practice was not designed for this. And you human factors people, you time and motion people could come along and say, look, if we were going to do general practice, as a mainly remote service, we wouldn't design it like this. And that is very evident when you go to an out of hours service, which was designed for remote. It runs completely differently. Nobody complains about phone calls in the out of hours service because that's what it's designed to do. So the processes and the workflows, so it may work less well. They definitely do work less well, even in the more advanced, more sophisticated practices. And a lot of joining up needs to happen, and staff are stressed. There's high cognitive load. Secondly, something I've already just mentioned, the remote encounter depends much more on history taking and dialogue. Therefore, verbal communication is absolutely mission critical, and staff need lots of training to do that. And we've just got a paper coming out any day now in British Journal of General Practice that shows staff are never trained to use the phone. They're trained to use pieces of technology. Almost no member of staff that we interviewed, we've interviewed a couple of hundred, they said, I've never been on a course to do telephone triage or telephone consultations. And we shouldn't be training people just to use the technology. We should be using them. Yeah, okay. Inequities. It's the usual list. I've already been through them. Because it's so dependent on talk and interpretation and getting rapport, guess what? Anybody with challenges to communication is going to do worse. I would say that staff make amazing efforts. We observe so many incredible interactions where the staff member is working with someone who's got learning difficulties or language difficulties or whatever. Now, some of those workarounds become normalized, and I showed you one or two in the examples. When those workarounds become normalized, they often increase efficiency, but other workarounds are very labor intensive and they don't appear to be scalable. The one-off, the member of staff who say, I must do this to make sure Mrs. Bloggs does all right, but it's not being routinized in the organization. And then this issue, of course, you can't do physical examinations remotely. Well, actually, you know what? Before the pandemic, we were evaluating video consultations in the remote parts of Scotland. We think those islands in Scotland are really remote. I mean, I know in Australia, remote is a bit kind of next level. And I remember visiting and seeing these amazing gadgets, you know, like a healthcare assistant would put the thing in your ear, and then someone 300 miles away would be looking at the picture, that kind of thing. So I get that you can have the digital stethoscope and the digital dermoscope and all that kind of thing. And we've done quite a lot of research on that. But mostly it's jolly difficult to take someone's blood pressure remotely or you know, whatever it might be. Therefore, the remote consultation has a very high degree of inherent uncertainty. You have not placed your hand on that abdomen, for example. Even when processes have been optimized, so someone's been properly triaged to get the right modality, but especially when the processes have not been optimized, the diagnosis and the assessment of urgency or severity are provisional. And in many cases, in many of those 95 cases, what happened was somebody spoke to the patient on the phone or a relative of the patient on the phone, made a provisional diagnosis, constipation, for example, but then the next person to pick up on that illness trajectory took that diagnosis as a fact rather than a working diagnosis. And that's probably the big message, that if you're doing a phone consultation, everything is more uncertain, everything is more provisional, which is why we have rules of thumb like 3 strikes you're in. So we've got some rules of thumb. On the basis of the 95 cases, these are the kind of things that we think in-person assessment is often required. And they are rules of thumb, just like guidelines. You know, you can always think of an exception. These are the ones that kind of make the hairs on the back of my neck stand up because I've read these 95 cases. And then, so those are the conditions. Then there's clinical trajectories. condition has not resolved as expected, or indeed has got worse after a previous remote. Escalating parental concern, again and again, parental concern being ignored leads to something bad happening. Acute condition overlaid on pre-existing complex illness. So that's mental health, but it's also saw some really rather horrible things with people with diabetes. People not realizing that the diabetes was actually not as well controlled as you might think, and then the person gets jaw pain, for example, and all that kind of thing. Okay. Patient level features, I think we've been through most of that. And again, there's nothing that is particularly surprising there, I think. One thing distinguishing whether or not the patient has a technology versus the ability to use the technology. I'll give you an example of my brother, actually, who's got mild learning difficulties. And he'd developed shingles, but we didn't know that. He'd got some rash, and he got through. I said to him, ring the GP. He rings the GP, and the receptionist says to him, have you got a smartphone? And he says, yes, I've got a smartphone. And she says, can you take a picture of the rash? He says, yes, I can take a picture with my smartphone. She says, okay, I'll send you a text message, and then I want you to upload the picture onto that. And then nothing happened for 3 weeks. And my brother was very sick with his shingles. So we went through this. Can you take a picture of your rash with a smartphone? Yes, I can. I will send you a link to upload. She didn't say, can you upload something? And so he could use the camera to take a picture, but uploading it, and then nothing it scooped back when he didn't upload it. You can imagine the GP practice got a letter from me about that one. But possessing the technology doesn't mean they can use it, is the point. Safety netting. Oh, you guys know about safety netting. If you don't know about it, nobody knows about it. Over scripting can be a problem with safety netting, but again, you know all that. Getting people to repeat it back. That's well known, I think. We also recommend organization and system level measures. You'd be glad to hear. Understaffing is not a good idea, but you know that. Optimizing workflows, all that kind of thing. Now, we think all GP practices need a particular protocol, a particular set of workflows when things get really bad. And I don't just mean your standard Monday morning, but when you've got 3 staff off sick with COVID, and because actually that is when, like the first one I gave you, the receptionist was distracted because it was just crazy. Maybe we need a different protocol for times of extreme stress. Relational continuity, I've been talking about that a lot at this conference, complex and vulnerable patients, training not just in the technology, and workarounds. Workarounds really important. Encourage staff to be creative, but then try and normalize what's going on. And then we've also got advice directed at patients, which was written by a patient on our author group who's, oh, she's not a patient, actually, she's a parent of a kid who had a safety incident, and she's a lawyer, and so she's working with a group of patients, and she's produced this based on our data. I won't go into it in any great detail, but this hopefully will get made into an infographic